Hello, everyone. I am Büşra Cangut, and today I am with Dr. Selinger, who is an associate professor of surgery from University of Maryland and expert in the field of perioperative blood management in cardiac surgery. And notably, he recently published a comprehensive ERAS Cardiac Society turnkey order set for patient blood management. Hello, Dr. Selinger. Thank you for joining us today.
My pleasure.
So, Dr. Selinger, how do you think we can best leverage blood utilization data in the STS database to help guide patient blood management?
Well, that's a great question, Bushra. And we have a lot of data regarding blood utilization in the STS database. And we may want to think about organizing it around the three pillars of patient blood management. And the three pillars are divided by the phase of care. So we may want to have some questions around the process and outcome of how programs manage anemia preoperatively, about evidence-based ways that programs minimize their blood loss intraoperatively, and then finally about how we manage anemia postoperatively, notably how willing we are to tolerate anemia in a patient that is physiologically well perfused. And in order to do that, I think our specialty really needs to think about not just hemoglobin triggers when it comes to transfusion, but what are really the appropriate physiologic triggers for a packed red blood cell transfusion? And also for what are the appropriate indications for blood component therapy?
Okay. My next question is, how do we quantify bleeding for our patients?
Yeah, that's a great question. If people have tried to do this, we have trouble with quantifying accurately our blood loss, both intraoperatively for sure, and as well as postoperatively. The existing scales that measure blood loss or try to objectively in the literature and in papers also include blood transfusions as part of the scale. So they're not really a pure measure of blood loss.
Mm-hmm.
And if you look at things that I would think of like chest tube output really only correlates on a very gross scale with the amount of actual blood that's lost. So it's also not completely accurate. So I don't know the answer to that question, but I think that's an important question for us as a specialty to try to answer to help us compare how different patients are managed across programs and compare results.
Okay. And my last question for this is a specialty. What other guidelines might benefit our patients in the future?
That's also a great question. And I think our specialty could provide additional guidance to surgeons on if a patient needs to be re-explored, what's the optimal timing of that re-exploration? Because I think there's some evidence that delaying that re-exploration can hurt the patients even more than the fact that they've already bled and need a re-exploration. And if we could find a way to identify optimal timing for re-exploration and then find a way to track those re-explorations in a way that encourages programs to re-explore patients that need it in an appropriate time frame, I think that could really help our patients.
Okay. Thank you, Dr. Selinger, again for joining us and giving your perspective about this topic. Thank you.
Thanks for having me.